Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and will take you through an exciting CTO of anomalous right coronary artery as the main agenda this morning. This is session number 57 and I'd like to welcome all of you. Please continue to send your questions at info@ccclivecases.org. Before we also start the main transmission, I'd like to congratulate the organizers of the recently concluded India Live Conference, probably the 5th meeting if I'm correct. It is obvious India is poised to be one of the leading countries in PCI around the world, and both Dr. Sharma and I attended the meeting and we felt this was an outstanding educational endeavor, and we wish you continued good luck. With these words of introduction, let me take you to the cardiac cath lab where Dr. Kinney and Dr. Sharma are standing by. Good morning, Anu. Good morning, Sameen.
Good morning.
I'm sure you agree with the sentiments about India Live.
Yeah, well, absolutely. I mean, India Live has now become the interventional meeting of India, just like China Live and so. And the organizers did a tremendous job. Everybody looks for it, and all the variety of cases shown. So always you can improve. And one of the suggestions I made was cut down the room so that you have more audience per room. But overall, it was a superb, scientific, rigorous, and all the varieties shown. So that I really congratulate the organizers of India Live to do this splendid, outstanding job.
I would also like to greet our numerous viewers in Saudi Arabia. It is a part of the world which I was not familiar was following us so closely. To Dr. Mehboob Ali, Sameen, he knows you from Fortis Hospital. They put up the first STEMI PCI course in GASM. So congratulations to you and good luck with all your efforts.
Beautiful. And really, we are ready here from our side, and actually, periodically we want our viewers to give us what they need, what we should do, and showcase. We always select amongst the multiple cases we have from educational point of view, and there has been a big demand of anomalous right coronary artery complex intervention. Knowing that the engagement of the right is difficult, anomalous left is easy to engage, although maybe more complex in terms of the management. But anomalous right is very difficult to engage, and I know over the years that one or two cases since we could not engage and very difficult intervention, that patient I personally have sent in last 20 years 2 patients for 1 vessel bypass because the anomaly of the right coronary artery. And of course we'll go through our publication which really highlight how to engage these cases by special catheters. So with that note, what we are going to do is, this is our we go to the slide set with our thanks for the supporters, so that we continue to enhance our visibility and advertisement, and these are the personal disclosures which nothing has changed. And this patient is a 76-year-old female presented a few weeks ago on with new onset of class 3 angina and dyspnea on exertion. She actually was not taking any medications, was not seen by any doctor except some local physician. At that time they did a ETT which was positive, and then did a CTA which showed 3 vessel coronary artery disease. Patient also had an echo which revealed moderate to severe MR with a normal LV function. That time cardiac cath was done. Patient had 3 vessel disease, and Anu will take us through that we did 2 vessel intervention, and right coronary was anomalous. Yeah.
So if you see here, this is LV gram with the normal LV function. This is the left coronary system. Patient had a stent. If you see in the circumflex, it is just going into the major OM2, and then also another stent in the LAD, 2 stents.
And both were the Promus element plus.
Yeah, and here you can see the RCA,
Promus
that is Premier.
Yeah, Promus Premier.
And then you see the RCA that is filling from the sorry.
The right collateral, see, excellent collateral to the right coronary artery.
Yeah.
From the septals, actually predominantly from the septals.
No suggestion in this view that you're dealing with the anomalous RCA.
Yep, not yet.
No, I'll tell you the reason why, and this is what happens. This is what I needed to teach, is that normally what do? You will go with the JR4, you are in the right sinus and you start rotating the catheter to the clockwise, and you wait for it to just see if you'll engage, whether it is anterior or go into the right side. And you know, a couple of times you rotate it, when you don't see it, we teach our fellows and everybody what you do is a non-selective picture. And the non-selective picture with the catheter facing just the right sinus, you take a picture, see whether the anterior takeoff you can see. If not, you pull back little higher, face to the midline, take a picture. And when you took a non-selective,
Anu, you would prefer this to doing it with the pigtail?
No, with because you have a GR catheter. I'm just telling you this how we normally go through the algorithm of finding an anomalous RCA. So you have a GR catheter, you will place it in the right sinus, take a non-selective picture which will tell you whether it is the normal origin or anterior origin. Sometimes you have an inferior takeoff, and all these things you can see just by a non-selective picture. If you don't see it in the right, you pull little higher, take another non-selective picture where you can see if it is coming off the midline like you see here. It is just in the midline between the left and the right sinus. And if you have not seen it with these two non-selective picture, then you face it onto the left coronary sinus, and then you take a non-selective picture which will give you an idea where the origin is. Many times when you have not seen with this, the question comes, what is the first catheter that you will pick to see whether it is coming from the left sinus. You can always go, if you are still doing a diagnostic, just go with the, if you are in the right, now let me just go over, if you are on the right sinus and you have seen that it is anterior takeoff, you can usually go again with, if you same you have the JR, just keep it facing anterior, take a picture, or you can try a no torque. If it is in the midline on the right side, in the right sinus or midline, that's when you take your AR catheter, whether it is AR1 or AR2 will all depends on the size of the aorta. It's better you take with AR2, you'll be able to engage it. Now the question comes is,
and we'll come back to this when we present our paper. Yeah.
Now I'm just talking with the non-selective. In this case, many times what you do, then you go to the RAO view, and then we place this catheter. So if it's in the midline, go with the AL. This is where it is. We took a picture. Again, we don't have a full engagement, non-selective, but at least we know where the RCA is coming from.
Very good. Now, and this is, then we'll be ready once the time angiogram point of view. This is the last picture here, right? Yeah, good. Yeah. Okay. Now we can go back to the quickly our coronaries where we are getting the engagement, and I want to do this case live because people want to see stepwise that how we are going to bring it to the ostium, that not necessarily you have to engage it. As long as you bring it near the ostium of the right coronary, that you are able to advance your devices. Now basically this case, 3 vessel, as we said, as a mild pulmonary hypertension, as 2+ mitral regurgitation. We did a good ventriculogram with the pigtail. I always say that with JR4, which Anu showed, this is good to get EDP and some idea about LV function, but if you are trying to see the valve abnormality or assess the ejection fraction accurately, you then change it to the pigtail, which we require in, I would say, maybe 10% of cases, and then do a good ventriculogram with a 30 cc dye at 15 cc's per minute at 450 to 600 psi. This patient had a 2 ulcerated lesion of the LAD and circumflex, and which were taken care, and of course this is the anomalous right. She continues to have symptoms. She also has a bad COPD. She was on multiple inhalers, so Spira, Advair, and so now because of this anomalous origin, we brought this patient for intervention with the knowing that the stress test, which was positive, will make it from appropriateness point of view that it is a mildly positive patient on double drug and class 1 to 2 angina symptoms. So that it is uncertain, which is okay, because many of our cases, not all of them are appropriate. As you know, the data has shown appropriateness is about like 50%, 40 to 50%. Uncertain is about another 40 to 40%, and inappropriate for the country is about 17-18%, and at Sinai that is less than 3% at present. So that clearly this case is uncertain by the criteria. Now what I'll do is quickly, and this is just to follow up what Anu just said, that bring this topic which we have never discussed about the anomalous coronary arteries, and people keep asking which newer DES is better. Are there any data to support one versus other? So basically from the anomalies. Now, as you can see here, that once the coronary originates, whether from the right coronary or left coronary, they can have multiple courses, and common being go in front of the great vessels, go between the great vessels, go behind the great vessels, or go into the septum. So those are the 4 varieties, and this is more common for I would say significant for the left coronary artery. And you see the interarterial course, the septal course, the anterior course, and the retroaortic course. Most which we worry about, which is the high risk, is the anomalous left main having an interarterial course coming from the right sinus. And why? Because it has been shown during exercise sudden death because of the compression, slit light opening, and this actually have been shown one of the common anomaly of the various the coronary anomalies which have been reported in the literature, but more importantly that it is a potentially serious. Because many anomalies like separate ostia, little myocardial bridge, and so those are there, but they occur the very benign. But the anomalous origin of the right or left coming from the contralateral sinus is considered as a potentially serious anomaly and should need to be taken care by appropriate measures. And what is the recommendation? I'll tell you. This actually has been shown that coronary anomalies are related to, are contributing to sudden cardiac death in athletes, and so, and the percentage contribution shown here. Now also this the engagement is difficult for the right coronary, for the left main coming from the right coronary sinus or right sinus is very simple to engage. So usually it's a AR2 or use the regular JR or sometimes the Lima catheter or multi-purpose, but the anomalous of the right is very difficult. And this paper which a fellow Kunal Sarkar wrote with us few years ago really goes through this that where this anomalous right coronary are originating from the left sinus of Valsalva. So Anu, you want to just highlight? So I know you were saying something earlier.
Yeah, so I think I mentioned you draw a midline, if you can see it, the right sinus and the left sinus. So it is on the right side. It's very easy. If it's closer to the RCA, you just go with the no torque catheter. If it's closer to the midline in the right sinus, you try your AR1 or AR2. So it's very clear. So it's no torque or AR catheters. Now when you come to the midline, and then you have what's called as the left sinus. Once you come to the left sinus, you have to be very clear whether you are above the sinotubular plane. Very simple is you have the left main originating. So keep it simple. If your right coronary artery is originating above the left main versus below the left main, and if it is above the left main, the guide, usually what happens when you are reaching to this level, you have to start engaging it with a guide catheter rather than the diagnostic catheter. But still, if you think an FL would be a better choice, and we don't get FL3 in the diagnostic catheter, it will have to be FL3 guide. And then if it's below the left main, that is below the left main, you have B and C, and that is very easy. If you remember, you just go with the ODA or FCL. So B and C is ODA or FCL, and D could be below the sinotubular junction, or you see the line, it could be anywhere along the line, and that is AL catheters. And whether it is AL 0.75, 0.1, 0.2, all depends on the size of the aortic root for that particular patient. So if you can just remember A, B, C, D and what catheters you use, this is, if you can go to the next slide, this is what we had gone through our cases, and just give you an outline. This is the best catheter choice. So simple FL, then if it is a B and C, you use FCL or VL. Just try VL first, and if you are along the midline, will be AL catheters.
Now our case will be in which category? Is that
we are D.
About D.
Yeah, D, just closer to the midline. So we use AL1. Again, we are able to engage it. It's not that these guide catheters are like normal catheters, means normal coronaries, that they go and sit in the vessel. It's rare they sit in the vessel. As long as you are at the ostium, you should be able to wire it and then do the PCI, which steps we will be showing.
Then there is a whole guidelines. People ask that now patient came in for some symptoms or asymptomatic, did a CT angio, and you find this anomalous origin of vessel. What are the guidelines? And it's very simple, that if you can say that once you have it, anomalous origin, you still need to go through all the issues, do the CT angio, but more importantly that the recommendation are that surgical coronary revascularization should be performed in patients with any of the following as a class 1 indication, that anomalous left main artery coursing between the aorta and pulmonary artery, very important. So the left main, even you find it's a class 1 indication between the great vessel, even if patient is asymptomatic. Then second is documented coronary ischemia due to coronary compression with coursing between the great arteries or in the intramural fashion, is also class 1. And then thirdly, the anomalous origin of the right coronary artery between aorta and pulmonary artery with evidence of ischemia. And this is very important, that interarterial course of the right coronary recommendation as a class 1 only if there is a ischemia. Now once you go to the second level of class 2A and 2B, there clearly shows that there you could, any patient could qualify to have an anomalous origin, should go for surgical correction. But the class 1 indication basically is that because reason is that this they actually did in correction of the coronary arteries, and they found that you follow these patients and do the stress test, they are still abnormal, but you don't have a sudden death. So that this leads to that which case should go, knowing that the sudden death occurs very rarely. I would just sum it up that management of the anomalous coronary artery from the contralateral coronary sinus, LCA from the right sinus, surgical repair in the intraarterial course, RCA from the left sinus, medical management unless symptomatic or ischemic, then they go for surgical repair. Stents do not have any role because it's a compression, so stent will not answer that question, and both groups until have a surgery should have an exercise limitation. So this is basically where we are in the anomalous coronary artery. Then I go to the second point.
Very quickly before that, how many patients in your career have you sent to surgery?
Oh, I sent just 3 months ago. One patient, atypical chest pain, left main coming from the right coronary artery, CT angio showed between the great vessel, otherwise normal coronary, sent for surgery. I would say every year from our lab, we'll of the 16,000 cases, 4 or 5 cases will send for de-roofing, reimplantation of this anomalous coronary artery. So that incidence just becomes the same what is in the literature, like 0.01, 0.05%. Now then the issue comes, what about the various newer generation stents, and what has changed in the stents is they're becoming thinner, the polymer become thinner or bioabsorbable, and of course there is a reabsorbable stent and various drugs which are less inflammatory, and so. Now this is the slide I have shown a little while ago. We had actually have kind of second generation DES, the 3 trials, randomized resolute all comer with a 2-year data, 20 trial of the 12 months and platinum trial of the 3 years, and you can see here seems to be equivalent in except in terms of the MACE, TLR and restenosis are no significant difference, with a lower stent thrombosis in the with the EES group compared to Zetterolmus resolute in a resolute all comer trial. So overall efficacy was equal, safety science was better in one of the trial. Now then we have the 5 new trials in last 2-3 years. The host assure, which use the platinum chromium ES, which is the Promus element, versus resolute endeavor the ZES. Second is the compare 2, which compared the absorbable polymer of the bioluminous eluting stent versus cobalt chromium ES, which is Zions. Then platinum plus, which compared the platinum chromium ES, which is a Promus element, versus cobalt chromium ES, which is Zions prime and V. And then sort out 6 is the resolute integrity, which is the latest of the resolute group with the ZES versus bioluminous eluting stent, and the 22 is the platinum chromium stent, which is the Promus element, the latest one, compared with the resolute integrity ZES. This is what we use at this time. Now actually we have now Promus Premier, which has come over the Promus element, and same thing the Zions expedition has come. We don't have the data of those. So I just quickly go with the whole concept, the host assure, actually very interesting trial of the platinum chromium versus the cobalt chromium with the 2-to-1 randomization. They also did 2 dual antiplatelet therapy. They give clopidogrel 150 milligram versus triple antiplatelet therapy with cilastrol, found no difference at 30 days, but the comparison of the platinum chromium and cobalt chromium shown here identical. No difference in the TLF, target lesion failure, death, MI, repeat revascularization and stent thrombosis. Second trial, the only thing is showed that there was a longitudinal stent compression, LSD, which we call a deformation in the platinum chromium, but not, with the platinum chromium and not with the cobalt chromium. Second is the compared 2 trial, which compared against with the bioluminous eluting stent, which is an absorbable polymer, compared to the everluminous eluting stent, 2-to-1 randomization, again showing no difference in the death, MI, TVR, primary endpoints and stent thrombosis. The third trial is the platinum plus, which is all comers, the Promus element versus Zions prime with the 2-to-1 randomization, and it showed actually the Zions prime non-statistically better in terms of the target vessel failure, and slightly they actually showed 30-day has a lower stent thrombosis, but at 1 year just there is no significant difference, 0.8 versus 0.5, but did have some signal of the Zions prime slightly superiority over Promus element. But again, the issue was the longitudinal stent deformation. Then there is the latest of this is a sort out 6 trial, which compared the Zeterolimus eluting resolute integrity with the bioluminous eluting stent, again identical as you can see in terms of all the endpoints of the MACE, TLR, TVR and stent thrombosis. Then the last in this field is the 20, remember, resolute versus cobalt chromium, and now they have resolute integrity against Promus element trial, 1-to-1 randomization, again showing the identical outcomes in every field of your MI, TVR, TF, MACE and stent thrombosis. So the equal in all of them as shown here. Now only one is the longitudinal stent deformation occurs in the platinum chromium, although they showed that none of these cases were associated with any bad outcome, but longitudinal stent deformation is the disease, is the phenomena only with the platinum chromium stent because of the vertical foreshortening. They have taken the one of the connection out to make it more flexible, but vertically still has shortened, although part of that has been now taken care in the Promus Premier because of the reinforcement of the proximal part of the Promus element with the platinum chromium. There are few other trials which we need to look out at. One is this EverBO2 trial, which is comparing the biometrics BES, bioluminous eluting, with Promus element versus absorbable stent BVS, and the Horizons AMI comparing the synergy, Promus element, EES, resolute and omega BMS. And these are the various combination of the DES which we will need to look for in our future to really that whether one is superior over other. Now therefore, if I would say the newer DS comparative data in randomized clinical trial, conclusion is no significant difference in MACE, TLR, restenosis or stent thrombosis, a small signal of non-statistical trend of lower TVF with cobalt chromium EES of the Zions group. Longitudinal stent deformation is unique to platinum chromium DES of the Promus element. And I stop here and we are ready for the case.
I mean, excellent review. It's not the easiest to keep in mind 5 trials with the numerous DES, but one of the issues which appears clear is there is no role for triple antiplatelet therapy.
Absolutely correct, yes. And particularly now, you remember even the dual antiplatelet therapy, they have looked into, they have only looked into with the clopidogrel, but particularly you have more stronger agents of ticagrelor and prasugrel. I am sure it will be a no additional role. Yes, now tell us Anu, what you are doing now.
Give me the new catheter.
Anu,
no, we are just there. If you can see it, this is the.
I am just taking a little picture now.
Somewhat
and just to say,
non-selective as you had mentioned.
Yes.
This is the AL1.
This is the AL1.
Okay.
The question
so
is,
how do we
AL2?
You try
AL2?
I think so. Let's start with that.
Let's try AL2.
Let's go with the AL2. Clearly telling you an RAO.
This also situation what can happen in this case, you can go to RAO because that will tell you what's the distance between anterior posterior. If you see here, it's not as Okay.
I think more difficult to make it out in the RAO.
Yeah.
But
no, we can see it.
The deposition from the diagram you had shown.
Yeah.
I think AL2 will be the better catheter.
Okay.
Samin, a question has come for you. Anomalous RCA CTO, why not leave it alone?
Well, that's a very good point. I know in this particular case, my reason was that this mitral regurgitation. This patient
Ischemia was inferior also.
Yeah, yeah, no, I mean the addition to ischemia, but more important is
ischemic basis of the MR.
Right.
Okay.
Yes. But that is true. But clearly, yeah, you are right. I mean, the point here is knowing that we are two good vessels working. In this case, will not be too aggressive. But I felt that this will be a very educational case for everybody, for ourselves as well as to our audience. In terms of the treatment of this complex right coronary.
No doubt, and I don't recollect our having done an anomalous vessel PCI. So.
Yes.
So it does have an educational benefit.
Samin,
you think the Premier stent has reduced the LST or eliminated it?
Well, I would say probably reduced it, because if you feel that you hold the stent, it still gives you the same feeling, but it has been reinforced proximally. You want to go to other view? That will be better. Go to that view. Our LO10 and caudal 6.
I'm telling you, that was sitting there.
But clearly has decreased, because now there are 4 different sizes of those stent or not sizes, means the combination, and what it has done is really reinforce the proximal portion of the 2-3 rings. And we actually, what we have used now, we have not found any problem at all with those with the Promus Premier now.
So
this
five DES, so many stents, so many p-values.
Yes,
what is your take-home message? What is your favorite stent today?
I think this is the same. It's not even getting engaged.
Yeah. No, I would say that it just basically then boils down to that in majority of cases you get your best catheter what you have, and what we are trying to do, the same at our lab, in our lab, that we have a good combination of both the Promus Premier as well as the Science Expedition. And key is that these are very deliverable stents, this new generation.
What about the Resolute line?
We do Resolute also, but key is that this is what, it's all one lab which becomes comfortable with one versus other, and those are very important.
Not that convinced about data for diabetics? Or?
Yeah, that's actually, that's an interesting point, that once you look into it, although the Resolute is approved for specifically for the diabetic patients, but if you go inside the individual data of these DES and the diabetics and so, that seems to be that the all seems to work okay, but just with the diabetic label, from at least in our lab, we are not changed the DES choice based on the your diabetic status. Now at the same time, now tell us what you are doing now.
So I think even with this guide, we are not able to engage well, which is typical of this coronaries, which I mentioned earlier. So leave it at the ostium, but have your tools ready. So there is probably 2 ways of handling this PCI.
And I'll
if you go here,
yeah,
right? No, this one. This is the one where we have a good picture, right? So if you go here, as long as it is sitting at the ostium, you have to go with your floppy wire, which is a fielder we have, and always go with your over the wire catheter. We have the newer super cross catheter with us today, with the fielder, thinking that we'll be able to wire the vessel with the fielder, then get your super cross wire almost to the mid RCA. Other thing that has been useful more and more that we are doing this anomalous vessel is of course guide liner. So we have guide liner up front already in the guide.
Right there.
Yeah. The only thing is, I think it's changing the shape of the guide.
Though you can pull back the guide liner a little
yeah,
bit.
We will.
Yeah. But since the guide liner already there, so that you already have that extra support when you will need to advance your devices.
So the first step will be, the first way to handle this, go with the fielder with your over the wire catheter, which we have is a super cross, and you have a guide liner there. If the fielder goes in easily and your over the wire catheter goes, you advance the guide liner into the RCA, and that's when you have a good guide support at that level. Suppose we are not able to do that, the second level of getting this good guide engagement will be, you go with the fielder, you have that first so-called conus / SA node branch, go there and balloon anchor, and then get your guide engaged into the RCA. These are the two steps that we are going to try.
Almost have
Pull
a
back.
feeling the second may be the more attractive possibility because
No, this I think AL1 probably was a better guide.
yeah.
Yeah,
we'll
this
try one
AL2
second.
has just changed the entire orientation.
Orientation, yeah.
Because
But we'll see.
using the guide wire to better stabilize the guide, I think will come up with the challenge as it reaches the mid portion. But I am truly glad we picked up a very unusual case.
Yes.
This is going to be interesting to see how you
No,
manage
take out
this.
take it out.
Samin, back to your excellent review of the DES. Duration of DAPT has changed or still stays
Get
1
us
year?
a fielder.
Yeah, so far we are still
New
keeping
fielder.
it for 1 year. Yeah. Now this is today we are using the super cross.
No, there's nothing to do. I think
no,
this
no,
what
no, I'm saying
happens.
crosswise. The which wire, which the exchange catheter we are using.
Oh,
The
super
we are-
cross.
Yeah, fine cross of Terumo is the one which we have used traditionally, and this is the super cross. It's not angulated, it's straight super cross exchange wire catheter made by vascular solution.
And here, yeah, by vascular. So this is the the curve. You need a big curve to get into the RCA, and once we are in the RCA, you can change the curve again. Get the yellow guide
Samin,
ready.
what are the characteristics of the supercross which make it more attractive than the fine cross?
Yeah, it is glide coated.
Okay.
Couple of tough cases where fine cross would not go. We have had this get into the vessel.
Yeah, I think the guide we need to bring a little further first. Yeah.
For our viewers interested in the Spanish simulcast, please follow that and the same criteria for
Send that.
sending your questions.
I'm turning it that on.
We need to bring a little more closure. It will not go by this. If this does not, we go back to the AL1.
Okay, now you try to get some dye.
Yeah.
No, don't. You have to engage it. Okay, go.
So you'll get the dye.
We're trying to see if we can have non-selective. No good.
I think with your all
AL1.
the additional equipments are creating a
Okay,
problem.
here we go.
Good.
Yeah.
No, now.
Good.
See, this is where, now can you go into the mid RCA? You
Just
are in
one
the
second.
branch.
Yeah. Okay, little dye.
Good.
Yep.
Stay there.
Oh,
No good.
yeah, that's
This
the
is-
problem. Yeah. I think I would not go with the fine cross right now. I think we would not means
Super
with
cross.
the guide liner.
You want to go with the 2O balloon then?
Yeah, but anyway, let's go slowly. This your we are going slow with super cross. No.
Okay, you know what you do? 2O balloon.
Yeah. So let's
this
take
out.
all. No, I would say even take this one out.
Okay.
Yeah. Take everything out. We get to a balloon and whatever.
Yeah,
we
I
need to do.
want to change it to AL guide.
AL
AL1.
guide.
I
Good.
don't like
Then get the L1.
this is, I think,
Go back to
just not
L1.
helping.
Yeah, but the key just showed that even if you are just close by, your wire will go, and so it will require. So let's take this one out. Or you want to just manipulate a little more if we can get a selective.
Looks fortunately no major calcification of the ostium.
Yeah.
Good. Good.
There you go. A little more.
Good. Just keep it there. Give me that wire first.
Wire and 2O balloon. You saw what I did was I went down in the cusp and changed the shape of the guide.
Right. No damping of pressures there.
No.
So back to
No,
the excellent techniques which worked in 1986.
That's it. The change the catheter shape, size, we used to modify so many of them.
And over the wire balloon support technique.
Yes.
I cannot. Guide is sitting
You
there.
keep holding, yeah. Release the wire. Good.
You may have the floor.
No, I'm okay. Put a torquer on that wire.
And the wire is the same fielder based wire.
Yeah, yeah.
Right now we are the fielder.
Go into the conus. You have to go with the 2O balloon, anchor it, and then we change the orientation if we can.
Just 1 second. Okay, just give a little dive now.
Yeah, the wire
That
has
is
made
out.
some progress.
Yeah. So that let me see if we can get
No,
this one
no,
further.
This is wrong.
Huh?
Will fly out.
Yeah. Just 1 second.
Go to the higher mag and bring this closer. Yeah, good.
We need to go a little bit on the vessel.
Now telling him the catheter wise.
Okay. Now we have.
No, you have
Keep
to get
holding.
into the.
Yeah, no. No, but the question is, let's see if we can cross.
No. You don't try that. You dissect it unnecessary. First, let's get the guiding gauge.
Now this is the 2O. What balloon is that?
This
2O?
is a 2O mini track.
2O 12 or 15?
12.
12 minute track. Now what you could do is you can inflate the balloon here to see and get the guide little closer.
No.
Huh?
You cannot go into any branch there.
Now, clearly you wish that the guide liner would have been here now.
Samin, you decided against having a contralateral.
Now we have it.
Yeah, okay. What, a 5 French there on the other
Yeah,
side?
yeah.
Okay. Just in case you need. Be interesting to see how many cath labs stock some over the wire balloons.
Yeah, we actually carry some, partly because of the alcohol septal ablation also.
Yeah.
Give the catheter here.
Okay, now let's say.
I don't know what you've done.
Okay, now we need to do, let's inflate, right?
No. I think the best thing is, I'm telling you, is to get the.
Anu, some picture at some stage so that the
we'll do
viewers
it.
can,
Yeah,
can
absolutely.
appreciate
Let me do
where
it
we
now.
are.
Yeah.
You're in the wrong.
Somewhere there
We're a
we've
little bit off.
gone
Not a little bit.
subintimate.
Quite off.
Yeah.
Let me see. 1 second.
Good. So now, yes, let's pull back the wire more and the balloon. Yeah. I think we can inflate the balloon and then bring the guide a little more coaxial.
Okay.
Okay. Yeah. And then we can put a side by side another wire. I think to me better would be now to put a side by side wire. But anyway, let's put a balloon.
Not
6A.
much angiographically doesn't look much calcification.
Yeah,
though.
actually it looked earlier, but now definitely not at the level, it doesn't look calcium at all. I read is there's a moderate calcium. Originally that was done in the different room.
Right.
And based on this, I would call it a no calcium.
Well, that is in some ways, hopefully that will be good news for us. But
Good.
you've
So
got
now what
enough-
I would say
enough
that bring the
challenges.
another wire side by side to go into it, and we leave this one at this time.
So what would be that wire which you would bring in parallel?
I think we probably need one. We need to inject the contralateral side, and we go a little more stiffer wire, whether a miracle pilot or some
Not a confianza.
or confianza, yeah.
So how many atmospheres are you there?
This is about 8 atmosphere.
Okay. I thought it may be even less than that just to anchor.
Yeah.
No, the vessel is big too,
Right,
so
yeah,
you need
yeah.
a bigger atmosphere to anchor
it.
it.
We need to put another wire side by side.
No, okay.
Let's get a contralateral injection first. And which will be your next wire?
No, I'm not happy with the way the guide is. Either we have to get a guide liner there, or we have to get the guide in better. This is just not letting us do anything here. If you deflate it, right?
Deflate?
Yeah, it might fly out. Yeah. Deflate.
If the wire can go to any of those small branches, that will be okay.
I
Go.
thought it would
Go.
move to the conus, but it's not taking
They're
that
not
course
taking
either.
that turn. Yeah.
Yeah, the tip is a little distorted now. I think I got into the conus.
Yeah. Magnify a little bit.
Now that's inflated.
No, gone.
It was an inflated balloon, so it's gone. I think what I would do, go with AL1.
Okay, let's go with the guide AL1. That was our plan.
This is too big, changes the shape. Get us an AL1 new. We are changing back to AL1. Believe me, let's have the guideliner in the guide.
Yeah.
Let's have the guideliner in the
Then
guide.
guideline or balloon, then you go with the over-the-wire system. Everything should be there.
Over the wire, or do we go with the 2O balloon, new 2O balloon? Right?
Go wait with the guide. New guide, one second. Wow. Just need a little bit push on other side there.
Just retrieving a few questions that have started coming up.
What are the questions?
I'm just loading that.
Go. So we're back to AL1.
Loaded up with the guideliner.
That's what we are going to do, but we will not bring the guideliner in the descending. We'll probably leave it in the arch. Give me the question is, do we go with the 1.2 fielder versus the
No, I
over
think
the
we
wire?
should go with the over-the-wire system.
Okay, then
Yeah.
give the over the wire.
Same.
Guideliner over the wire.
Yeah. Let's load up everything together. Remember
Yeah,
the
yeah,
way
yeah,
that
yeah.
always comes. No, but we have our
Supercross. Where
Supercross.
is it?
Supercross with the fielder wire.
Maybe a new fielder because the tip
Yeah.
is all distorted.
We got the new fielder.
Okay.
Yes.
Yes.
Anu, this
Yeah.
is the Dr. Arun Padala. How about using a Sherpa 3D guide for anterior takeoffs? It has worked well for some cases.
Yeah. For
Yeah.
particularly if they are coming from the right corner.
Right sinus.
I mean, right sinus.
Yes.
But remember, this is coming from the left sinus.
Midline to left sinus.
And clearly that those Sherpa 3D RC would not make any luck there.
Good.
Right, Arun, there is your answer.
Okay, go in. Go in here. Pull back. Good. Okay. Advance. So now we are going with the guideliner, supercross inside the guideliner, and we have the fielder inside that.
We knew this will not be an easy case, but this is what we wanted to show.
Look,
The various steps and so on and so forth.
Excellent case to have selected,
Yeah.
and we had admitted right up front this is unusual. We haven't covered any anomalous, and I thought your review was outstanding.
Yeah, because it's it's very interesting that even in the right coronary,
some diagram.
yeah, that even the right coronary originate going between the great vessels is not benign.
Right.
So I used to kind of leave them alone, but there is enough data to support that. Why is your hair now? Yeah.
Okay, now?
Yeah. Let's get the guide a little better.
Okay. Go to the same view, right?
Yeah.
10:6. Maybe this left side catheter is.
Yeah. What we are going to do is JL may be preventing the movement. So for the time being, we'll move the JL back.
Okay.
Yeah.
There.
Really, the issue is more of the shape of the guiding catheter.
Yeah,
It
good.
is not issues such as support, for which a 7 French based system, I mean, that would also eliminate the few choices you have in catheters.
Yeah.
Yeah.
Okay.
Again, same we are able to.
Similar
Now you can go
situation,
into any
yes.
branch there, or cannot?
Did you change the shape of the wire or the
No,
same
no, no,
shape?
it's the same shape.
Okay. Just back to the AL1, which was
Little
your
back,
initial
little back.
choice. And there comes the balloon catheter.
Okay, that's all you get, I guess.
Just 1 second. So now what I'm going to do is, let me just advance it. No.
Conus.
Little dive.
Conus,
Is it in
conus,
some conus?
conus.
So maybe.
Leave it there.
No. And then we can put another. No, I would not go.
As soon as you advance, it comes out.
Yeah.
Okay. Can you just give?
I think to me the guideline is not helping. But anyway, let me bring this catheter. 1
It's
second.
not.
The
You need your wire a little further.
I know. But let's get a super cross in the wall.
So, I mean, were some of these technical issues discussed with the patient? That did somebody give the patient an idea? Look, this is not going to be a walk in the park.
Yeah. No, actually very interesting. We did discuss with the patient. This is the patient who has not gone to the physicians for many years, truly, but now she was so symptomatic. So we asked her also that what would you like to do, that there is still one more blockage. And patient, the Russian speaking, as you know, they are very adamant in terms of getting any procedure done, and so she felt that now it's about time that she willingly wanted to get this intervention done.
Well, just to tell you the
want to
resources
engage?
we have at our hand,
Engage.
if you need translation,
That's
we
it.
have a Russian fellow in the control room.
Yeah.
No, no, we don't need anything. No, left side.
Okay. Good.
I'm trying to see if the guideliner can.
Yeah. Now the key is that let me
Can you just
a little more wire. Okay.
let go?
So far as Samin, your extensive review of the coronaries was concerned, are there any racial or ethnic bases? One population having more anomalous arteries than other? Anything which? Nothing?
Only thing which has been described is that in South Asians that they have more left dominance. The usual dominance is about 85-90%,
Right.
the right dominance, but the left dominance in about 10% of cases.
Give
but
me
in the South Asians,
Ultima, bro.
Indians, and so that left dominance is almost 25-30% of cases, and that we have seen in our Indian continent. That left dominance is almost like 1/3.
You want to inject from the left side?
Take a little picture.
Yeah.
Well, it's a helpful view in telling us that there is a long road ahead.
What wire you need now?
This Ultima Bro.
Okay. The
Miracle 3 Ultima.
Okay, there is a new wire. Tell us a little more about
This is a Miracle 3 which is actually called as Ultimate Bro, because the thing is, you know, the Miracles they are hydrophobic, the tip. They are not tapered, hydrophobic, 3 grams. The only difference is this has a hydrophilic coating. The tip has a hydrophilic coating. But they don't, we do not carry the 6 at this time, we just have only the 3. Same very short tip, otherwise you have the confidence already there.
So at this moment, Anu, what help is the guideliner providing you?
Nothing.
Nothing at all.
Yeah, because
We just have it because if we cross and we go further down,
Okay.
that's the only time we may able to use it. But we saw that as soon as we advance it, everything is coming out. So you do nothing, backup, which is in the descending aorta.
And you just have us for the support the 2O balloon catheter.
No, this is the supercross
It's the same
catheter.
supercross back
Supercross,
again.
got
Yes.
it.
Your 2O balloon is out. Earlier we used that. Now we are back with the supercross. Want to give other injection? No, not you.
Yeah.
Retrograde.
Yeah.
Is the wire red and did
Now this is
somewhere
taking
it
the
takes a
fielder
different
course.
Yeah.
Fielder course, and this is what happens when it's okay. I think now you need the confianza. I think we are there.
Anu, more of a drilling motion with the wire?
Yeah, back forth.
Okay, somewhere there it takes a wrong course, but
Okay, get the-
clearly is more promising.
The confianza.
Yeah.
So escalating up to the confianza, I heard.
That's it.
Okay.
So the fielder, Ultima Bro, which is Miracle 3, and then confianza.
Any difference you'll give in the shape, or the shape is not?
Shape is the
super-
same.
That's
no,
very
super-
short tip.
Right. Okay.
I always tell you, don't go with this
Much
stupid
more
fielders.
stable position with the guiding catheter with the super cross there.
Yes, and having the O, one with the AL1 also sat little better than our AL2.
Samin, a few housekeeping issues here for me. That you've started registration for or starting soon for the complex coronary symposium in June.
That's it. And
how is that coming up?
Well, we are just making a final changes. Should be ready for our ACC next week. And actually, we have always our target that have the brochure ready at the time of ACC. And this year, we actually both Saturday and Sunday, we have a live relay from here to our ACC for noon time for almost I think it's about 75 minutes each day. We'll be showcasing our complex coronary interventions and bifurcations and various atherectomy techniques of the orbital as well as rotational and so.
Wonderful. And the venue is the same. The course, like all these years, conducts at the Mount Sinai Hospital.
That's it.
Few institutions could boast of better facilities and in-house broadcasting excellence.
Yes. That's correct. And that is actually part of our CCC.
Very difficult to do. Look, I
Some
run around the world trying to chase good hotels and companies, and I know exactly the skills you have here.
You want to go to RAO view? Okay. We are going to the RAO because it looks like that after exiting from the initial part of the total occlusion, it's taking a little different curve.
And this is the confianza wire.
Yeah.
Some dye in the anti-grid.
Okay, integrate also.
No, no.
A genuine, difficult CTO with the added complexity of anomalous
I
origin
think we are
of
in
the
a
right
branch.
coronary
No?
artery.
Yeah, that's okay too.
Show me some dye. No, I mean, go to the other side, other
Yeah.
side. If we are in a branch.
Same. Then we go to our LAO 10, 6. Good, right?
No, I don't think you see it. True LAO.
Huh?
Not true LAO because you have to inject contralateral now. Yeah.
Okay.
Are we in a branch? Cine.
We are in a different branch, not the main branch. But we have crossed through it. Get a grand slam.
We are this one?
Exchange length, yeah. You want to try navigate?
No, no, no.
Huh?
Not at this time. Navigate what? Get this down, right?
Okay.
Anu, it is way too early for an idea of a retrograde to creep in your head at this time.
Yeah, probably not retrograde here.
Okay, that's what I thought.
No, I mean same thing, like people ask what would you do in this particular, how aggressive would you go? This is a kind of case, I would say that if you cannot go, if we quit, no harm done. Where retrograde, yes, may increase the success a little bit more, but at the same time it's a little more
Much more technically
more complex, complexity, and so
absolutely.
yeah. So
One of the most important challenge in retrograde is getting the wire into the guide. And we
Right.
don't have a wire that the guide that sits in the ostium of the RCA.
Excellent point. Yeah. Yeah, to externalize this is going to be a nightmare.
I'm going to cine this now. Now you see that no injection, that the guideliner is being advanced.
Can I just have
Okay.
it feel and then, okay. Can we have so that we are watching with the
So, I mean, why did you decide to advance the guideliner? I thought we have a fairly decent situation with the supercross there itself.
no, we're trying to see no because right now
Could
not
lose
helping.
this.
Yeah.
Because supercross is not going further.
Right. Okay. Why? Because the wire is going somewhere subintimal.
No. Wire is in the small branch. It has gone into the vessel after the total occlusion, but in the lower branch. We should show that.
Yeah.
See mine?
No.
No,
Go,
okay.
go. If you can get your supercross there.
Okay, let me get supercross further.
It is coming out now. Okay.
For our viewers also, just like before, most of the videos will be available within a week's time, and you would be able to review this.
Now even we lost the supercross.
Yes, a fantastic case to demonstrate the need of skills and equipment.
All right. Some dye there. Are we in the? No, forget that. It came out.
One thing for sure, I think we should take the guideliner out. If necessary, we can put 2 wires and so.
Yeah,
but the guideliner is.
yeah. There was this
And,
lurking feeling in my mind that with the advancing of the
Guideliner, yeah.
that was the risk we were taking. But
Yep.
so we
No,
are back to
if
square
no,
one.
if the no, since your catheter is not advancing, you needed some push.
Yes, absolutely. Look,
The
I
question
think that
now,
gain was clearly in our mind.
get us a fielder to a balloon and we have to engage the.
And you've already learnt enough
Some
about
dye?
this case.
So why don't we go with a 1.5 balloon now?
Yeah. No,
Go-
1.5 balloon. Why?
1.5 balloon and the any one of the wire, because we know that we have created a lumen now. Actually, we can go with the fielder or any wire with a 1.5 balloon.
Problem is this one.
And what balloon we have? 1.5 watt now? Okay, 1.5 apex push. Huh?
1.25.
1.25? Okay. Let's get up. I think if once we are going, maybe go with the the smallest one, which is 1.25. The Sprinter, Legend.
Only thing is this curve, we may not be able to go through it. Remember, you needed a very small tip curve.
Yeah, no, but since we created a lumen, it should be able to go now. But then we can put a second wire side by side.
Fielder created a wrong lumen.
Yeah. No, but once you have the balloon there, we can bring the guide slightly closer, and then we put another wire side by side. That will be the, yes, Fielder created a different lumen.
Okay, there now.
Yeah. Go this now.
Now we have 1.25 balloon, Sprinter, Legend, with the Fielder.
And the guide liner out.
No, guide liner is out.
Okay.
Yeah, I think the guide liner pushed it back.
Yes.
Otherwise, we were making some progress.
No, we were not making progress because
No, but
if
we
the
have brought
over
another
the
wire. Yeah.
yeah.
What I'm saying is we could have brought another wire.
Okay, some dye there.
Would be
Okay,
interesting that
Yeah.
Anu had foreseen all of this in her initial challenges when she mentioned that. And
Good. Change the shape again. Okay, no.
this is the case with having a plan A, a plan B, a B1, a B2, and everything thereafter. Okay, the guide has slightly lost its shape.
Yeah.
Okay, there you go. Just I had to utter that. And
Will that you have to be holding? No.
also fairly large RCA.
Yeah.
Huge.
I think we need a new guide.
New
The
guide,
question is AL1 or AL2?
AL1.
Yeah.
Keen to know what Anu would choose, but I think she would tend towards
A more stiffer guide. Do you want a little stiffer of Sherpa and so if we have it?
You don't
AL1?
carry them, right?
Well, let's see. Do we have AL1 Sherpa?
It will keep the shape. Okay. Also remember we had taken this out.
Yeah, good.
Good. Don't keep giving dye when they.
Don't give dye. I will tell you where to give, when to give. Because many times the dye injection,
Wrong place.
will throw the guide out.
Yeah.
yeah, the wire out here.
You don't have a AL1. Open it. Open it. Some dye.
Will dye more?
No.
Samin, on to a
Some
totally
dye.
different topic.
Yeah.
How much of the assist system are you using?
Most rooms have it except 2 rooms, which is this room and other room where most of the complex PCIs are done.
That means engage
Yeah.
a little bit. Let me engage a little better. Come. Get your guide. Second one. Now, what is happening with that catheter?
Which
No, left.
you have this is the Sherpa. Maybe we want to try the Sherpa.
Yeah, let's try the Sherpa guide. Okay. Get very little dye.
Okay, there.
No, not yet. Little dye again. Okay, little dye again.
Check it out.
One little dye once again. No,
this
they've lost.
guide is behaving totally differently now.
Yes.
No, so we are going with we actually only have a 0.75 AL 0.75 on the Sherpa. No AL1 we said.
Never know, that may
Yeah, may fit because
Yeah,
of the way different shape.
The
Yeah.
shapes from different companies are totally different.
Yeah, yeah. Let's take it out. Good.
Good. All right. So now this is a 0.75. Will die
Yeah, probably it's a better shape.
now.
Guys. Okay, good. There. Little
For a
higher.
moment, it was almost at the ostium.
Yeah.
No. I think this one will be too small.
Not too small. It is shaping. Yeah.
Okay.
No, no, no.
No, you
More.
will die. It may be okay. Let's go.
No.
Okay. See.
Okay.
See now. Play the last one, guys. You're over the wire system, right? You're going with the over the wire system or no?
No, balloon.
Yeah, that's what I'm saying. Balloon. So why are you putting this? Go through the
1.2 is a monorail, no?
1.25,
Wait,
okay,
wait, wait,
monorail,
wait,
okay,
wait, don't
wait.
We are saying monorail.
1.25, okay. All right, so we trying again.
This does not work. Wait.
1.25.
In its strain, this is a 0.75 and it is looking bigger than the 1.0
Yeah.
which you had before. So, Samin, what would be, I mean, you have to be exquisitely careful to be sure that it doesn't injure the ostium, no?
Yes, that is true. Absolutely. That is one of the issue remains.
Very
That
subtle movements, yes.
Yeah.
Yes. Unfortunately, the soft tip, is this with the side holes? It almost looked
This
like
has
the
a
wire.
side holes.
Yeah,
It
okay,
came out.
The wire did come. Okay, that's
no good.
it will make your
Some dye?
visualization even harder.
Move it a little bit, no?
Now.
I think dip down. It's facing down. Make it face up. Yeah, that way. With the it's facing
Very
down, very stiff. Okay, yeah.
I think this is not helping.
I think a multi-purpose may.
No, not multi-purpose. Will die. No, I would just still say that we need to go with our AL1. This is nowhere closure.
No, no, wait, maybe.
Huh?
Let me do it.
Yep.
It's like. Okay, there. There. Okay. Yeah. Good. Engage now. Quickly wire.
Okay, here we go. So after 1 hour 20 minutes, we are back to where we were.
Except that we have made a little channel.
I think you've understood the anatomy. I mean, just the way I saw Anu manipulate the wire, she had a good sense of how much curve and where exactly to. So we'll.
But yes, these are the cases, troublesome. As I mentioned, that it's very frustrating to do PCI in these cases. So we wanted to take the challenge.
Absolutely.
Oh, okay.
To
Now we
advance
go
a
back
little bit
again.
further.
Yep. Wire. Okay, let's go back to this position again.
Okay, are you there? Yeah. Good, good, good. Advance the wire a little bit more. I tell you, these are like. Pull back.
Other question is, as soon as we go, should we go with a simultaneous another wire at this time? Give me a run through.
And do what?
We are off now. We are. Okay, just hold it 1 second.
What you're trying to do now?
Just 1 second.
What
The
will the
key is
run
that we're putting a one more wire side by side.
Giving it a slightly different shape though? Or?
Yeah. I mean, shape is still
Yeah, about not much.
different. Yeah.
And what is this? This is the run through?
It's a run through.
Okay. So maybe it will just track a slightly different
Yeah.
parallel
Idea
to
is
the-
that if we can get into, so get one more support.
Go with the 2O balloon and we anchor it in the conus with the run through. Go ahead, that's in the branch.
Slightly different course there.
No?
And to give injection from other side.
So looks
Okay.
a slightly different course there.
Yeah, run through has gone into that branch.
Yeah.
Yep. Which we want to try now.
Would you want to
Wait, 1
advance
Yeah.
1 to 5 balloon
Yeah,
a little
that's
more?
we are going to do now. One
Take
second.
you, change your gloves.
Yeah, I know. But let's. This is the
No,
second.
no, no, no.
This
So
is the wire.
We go on the run through wire.
Huh?
The balloon is
Yeah.
in a different wire.
Okay.
Get
Let's
us the
take this one out. No, let's take this
2O,
balloon out. Let's take this balloon out now. We are in very good position.
And you
Leave
want to
both
keep-
wires. Take this one out.
Yeah, you
Yeah.
want to keep the second wire
Yeah.
there still.
Yes.
Just switch the balloon over to the.
Yeah, yeah. Take it out slowly.
Okay. No, same balloon will do. Okay. Off.
Balloon was on the fielder wire. We are
Right.
taking the balloon out of the fielder wire, which is a 1.2,
And putting it on
and
the
then
run
we
through.
go on the run through. Now the question will come, once we inflate there, do we go with the guide liner?
Don't think about guide liner right now. 1 second. The balloon is stuck on this wire. Good. Yeah, run through. We have been so good with the run through wire, as you can see here.
Clean, well. Let me do it.
Good, it's good right now. Good.
Always important that you clean these wires.
Yes. Otherwise, that will.
Yeah, sticking
Stuck-
of the
stick it
balloon
in.
and all these things very important.
Do everything on floor.
Patient
And,
on patient on bivalirudin.
Yeah, patient is
I
on
think,
bivalirudin.
Okay.
And
With
if you
other
see
wires.
one person,
The other wire has come out.
that's okay. I don't know why,
That's okay right now.
Uh,
Yeah.
because you are holding that wire.
Yeah.
So we're going with the
may
1.2.
have been a blessing. Who knows?
Yeah.
Don't know. See, the guide is just sitting outside.
And run through should provide a little better support
Right.
than any of our fielder wires and so.
Gone more distally there.
Yeah.
So I'm just a little jiggling movement. Okay, you can go up here, create a. Now when we go up, we can always try to see if we can get the guide in better engaged.
Although you will not see this 1.25 balloon at all. Good. Now here, put that second wire back into the vessel here.
You're doing it more for support or
Yeah,
seeing it may
both.
track a different
No,
course?
no, support.
Okay.
Tip
Right
is
now I
probably
need extra
gone.
body in this
Yes.
wire.
Yes.
That's I mean
The
in the.
balloon may not let it go.
Yeah.
Yeah.
No, it'll go.
There we go.
Good. Hold it now. Good. Now let's get
I
balloon
wanted
further.
to engage the.
Don't worry about the wire now. Don't worry about the other wire.
Yeah, okay. Go up now. Telling you, if we successfully predilate here, then we need we are the 1.5 balloon.
So Anu, you were going to
Get the
to track your thoughts further. You were going
Yes.
to, I think, mention the guideliner, no?
Yeah.
But
Believe me, I know you guys are all against guideline.
No, we
Not
are
yet.
not. We are not
Yeah,
at
yeah.
all. We love it and like to see how it would do here too.
But for the guideliner to track, you need what is called a balloon anchor here. So we need to dilate here once, and then we get a 2O balloon, and when you have an inflated balloon, guideliner will track on it.
we have 1.5 apex push. I think that should go.
Okay, you can try that, or you can get the 1.2 mini.
No, 1.5 apex push will go,
Go,
but your
give
other
me.
wire has to be in the body.
Yeah, you
It's
have
not
to
going to the
reposition.
body. Just keep that. It's not doing anything anyway. It keeps coming out.
That's okay. But you need wire into the right coronary artery. And no, it comes out, but it will give you support while you're advancing your other equipment.
Okay, I think we take this out now.
Okay.
No.
It's about
Go.
the same.
Go up.
Go up.
Even if it's a little bit.
Okay. Negative.
I think we're wasting time trying to get this wire into the RCA. Let us the other balloon.
So that was the
Now, can you
two-
make
2O?
sure? This is the 1.2 sprinter.
Legend, but hasn't crossed it yet.
right. So I mean BVS case is coming out good.
So far, yes.
Okay. Looks like it is finding a niche for the younger patients
That is correct.
in India.
Yeah. And the trial here is of 2200 patients. 2000 patients have been enrolled in the Absorb 3, and I'm sure will be done within
How
2 months.
How many have you enrolled?
How many we had done? So
41.
far? About 40 plus. No, wire has curled up again. Good. See, that run through gives that power. Before we do, can we put another wire a little further in the proximal area? Yeah, that's okay. Leave it there. Bring the other wire also.
Wasting time. Tip of the fielder might have changed now. Good.
Well, change not only. I am also thinking that at some stage you should even consider that we've done these multiple dilatations, multiple wire entries. You may be surprised patient comes back after 3 months and you'll have a perfect track to go back into.
Yeah, that's true.
Okay, now
You need a little more.
go up this 1.5. Contralateral, see where this wire is distally. Okay,
A branch.
It's a nice sized branch.
Yeah.
okay, go up.
I mean, here clearly your guideliner, if you can get, will be the winner. But if you can get, you can only get if you have 2 wires there.
That's the 2O balloon.
It's a 1.5,
1.5.
but still has not crossed yet
Right.
to the distal part. Can I just help? Let me help you this one. Let me put this wire. Just 1 second. Leave everything alone. Off fluoro.
It needs to be reshaped a little bit because the okay.
Let us a 1 to 1.2 mini track.
I have a 1, 2, 15 minutes.
Yeah, 15.
15.
No, they are smaller. No, 6 and 8.
Really?
It's not going to go. Don't even try.
Then
Nothing. Take everything, take it out. We go with the mini trach. What has the 1.2, 15? No good. Nothing else? 12 is what we don't have. Take it out. Just wasting.
now you want to get the guideline.
I'm going
Take
to
a
do
chance,
that.
right?
Yeah.
Okay.
Take it out.
This wire is of no
Out.
good. Yeah.
And take this balloon out, which I told you not going to work. 1.2, 15. You don't have shorter, 12. What's the 12 we have then? You have to get one of those.
Okay.
What's the other mini track you have? 12, 8, nothing?
So we have only one size, but let's go with the guide liner first.
Nothing? 1.5 what? Yeah.
Then now we are pushing the guide liner.
Hopefully with a different outcome this time.
Yeah.
I think so, because the wire is so much more distally.
Yeah, and it's a run through.
It's been anchored into a very nice.
Okay, give the
some RV
one.
branch
We are
there or
going with the
something?
1.58 mini track now. Don't connect.
Wire. No, but good. So far, so good.
Don't connect.
Yep.
Oh,
No, slow.
Yeah. I was not watching it.
Let's set one the wire first. Oh yeah. You want to connect now? Good. Now
Yeah,
we'll
connect.
Okay. Go up. No, let it go up. Right now. Go 6, 8, 10, 12, 14. Good. Now bring your guide liner. Now you see that we inflated the balloon, and now hopefully we advance the guide liner.
Problem is it changes the shape. There's such a stiff guide. Not getting the guide liner through easy.
Exceptional skills there. Using
Advance the
the
wire.
anchored balloon and
Advance the wire a little more. Good. Good. Now
Okay.
the guide liner. Good. Deflate, right?
Wait.
Wait.
I'm trying to see if the guide can go a little further.
Good.
You saw that unless you have this balloon anchor, guide liner will never go forward, go down.
And now you can.
Now I can try to see if I can get the balloon further down. in.
opens up many more possibilities now.
Yeah.
Now this may go down. Go up here.
And keep advancing the guide liner a little more every time you inflate. Good.
Anu, not much role of taking a deep breath or something. In,
Not here, not here.
Yeah, that's what I.
Deep breath may change
It
everything.
may throw out the
Yeah,
guide.
yeah.
That's the problem in this case. Good. Now 1 second. Deflate, and I'll tell you what. Advance the wire.
Much
And,
more.
and the deflated balloon, advance the guide liner. Yeah. Advance the wire now. Good. Now advance the guide liner with the deflated balloon.
No.
It will go. Guide liner will go now.
Okay, go up here.
You need further. It's the same.
You think it went further, or we are about at the same? Very hard to know.
We can go now with the 125 new 125 balloon
Yeah.
on this one. Okay, down. And right now don't give any dye to see anything.
Going with the 1.25 new sprinter legend. And we don't have the over the wire, will be a little difficult here. Otherwise, Corsair could be a good choice to go through this difficult lesions. Now, wire need to go a little further again.
Yeah, but I'm sure you're willing to bet that this is going to go much further now with the guideliner there. Lost a little wire position there.
Should we go to the other branch? No?
Just keep advancing. It's a very curly branch.
Good, gives you more support with the doubled up wire there.
Beautiful. I mean, this run through is just so atraumatic and was so helpful.
Okay, good. See, it went through.
Much more distally, yes. Maybe too distal there.
Good. Let's go up. And we get a 2 or 20 compliant balloon. 6, 8, 10, 12. We'll never see it. 6, 8, 10, 12, 14. Yeah. It ruptured. No, sorry, not ruptured. Good. You want to advance the guide a little more? I mean, guide liner?
No,
Okay, negative.
it's not, you don't see it.
Yeah.
If it's not anchored, you can't do anything. Okay, go up again. Only question, how do we...
Did you deliberately bring the guideliner
No,
back?
no,
or
it came back.
It just came back.
It came back. Okay,
Negative.
down.
The guideline, we are trying to bring it back in again.
Go up here now.
Yeah. Go up here.
As you withdraw the balloon, advance that.
Yeah. Good. Now you want to bring the guideliner now?
It will not go.
Hmm?
It will not go. You need a good anchor. See that?
It'll go slowly. Yeah. Good. Go all the way. This is the best chance we have. Good. We need a 2 or 20 compliant balloon now. Good. Okay. I'm deflating, coming up. Good.
We are in the branch.
Yeah, that's okay.
Now, but how do we have to get to the main branch?
Yeah, we'll
do
do
we go
that.
side by side,
Yeah.
but with the guide liner. We try to use this wire. So we had, this was a new 1.2,
And we
which
should
was a
see-
sprinter legend.
Yeah, you want to see a little bit first?
Damped pressure, you won't see much.
Okay.
You want to see a little bit? You could. The question is, can we get into the little bit, because there would be air also. Good, right?
Take a little picture.
Don't inject hard.
Yeah, we can go into the side branch
Very
with the
little
new
dye.
wire.
Very little dye.
Yeah.
Yeah. Should we use this bar? No, let's dilate it first.
Yeah.
So actually we have now damped pressure because of the guide liner. You saw we gave very little dye to take this cine, just a CC, and you have
There's a
damping.
lot of diastasis there.
Yeah.
And you need to worry about with that diastasis.
Absolutely, patient will go into
fib. Yeah.
EFib, yeah. Yeah, but this is the same catheter with the side holes, no?
Yeah.
No, but a guide liner takes all that
Damping,
out.
yeah.
Damping,
Yeah.
go up.
You pull back the guide liner so that the dye
No, let's
washes
do
out.
that. No, right now don't do it. That's why I don't like the
Two
dye.
or
Okay, down.
20.
Yeah.
And it'll go, it'll take out in the
Get
side
this wire
branch. Yes, I
further.
know. You know, the fire further, or do we use this wire to go to the main branch now?
Okay. But then guide liner has to be back.
No. Okay. go up here a little bit. Let me see if I can get it into the main branch now. Okay, down. Because now how to get into the main branch is either we take this wire from the side branch, go to the main branch, or we have to go side by side. But when we go side by side in the guide liner, at the entry site, we may lose the curve of the new side by side wire, entry side of the guide liner. Same?
Same.
Maybe a new fielder wire with a slightly different shape.
We need a torquer to make this turn here. That's
There you
it.
go. There you go.
That's it.
That's
All right.
it. We are in.
So after 96 minutes, finally
Good.
light at the end of the tunnel.
Let's go.
Bright light. There could be
Bright
some.
light, absolutely. No, I think
Go.
now from here onward it should be. You're in the right branch. Your gut instinct of the guide liner was exactly right.
Down.
Okay. Go a little further. Yeah. Since we use the Promus element last time, we'll use the same.
Down.
3038.
38. Same thing. Right now, you don't move your guide liner. You know where your distal part of the stent has to be. Go there, place your distal part of the stent. Then you move,
Good.
pull your guide liner back. You don't have to pre-dilate. Nothing. 3038. Element. Promus Premier.
Promus Premier.
You're really leaning on your instincts here for choosing the length of the stent.
Yeah, no, once your guideline is there, it will go.
No, but we never really got a good idea about the length of the lead.
No, if you see
but
that.
no. Remember by the
just-
collaterals, we knew it
yeah,
was very
okay.
long.
No, long. Plus, you start just at the conus, you start seeing the vessel tapering, and the lesion is after the RV branch. So, you got to cover everything.
I fully agree.
If we are
and,
2.75 38, that's okay also.
Okay, go.
Vicky, 2.75 38.
What they have? 30.
yeah, it's a large vessel.
Yeah.
Let's go 30.
You can always post dilate.
Cannot find.
It's going to look a spectacular vessel by the time you're done.
That's all.
And it's
Then we are give the.
We are
summary
32
tip.
only?
I
3 or 32? Give
I
me 3 or
also
32.
think your efforts will be rewarded because the distal vessel is very healthy.
Yeah.
No disease there.
And our key would be that we'll do the echo tomorrow to see what are the mitral ligaments. No, we have it now. Yeah.
3
That,
or
how is the
38?
MR?
Is that normally the time course you do? You don't want
No,
to
I
wait
mean,
a little bit?
but remember we had done, we actually published, that was one of my very early paper when as a cardiology fellow or interventional fellow in 1990. Then we said that once you have ischemic mitral regurg, contrary to they say that you need a dominant vessel, which we said that no, because in MI's situation is different. In patient with a myocardial infarction when you rupture, but in a chronic ischemic MR, it is the multi-vessel disease in these patients, it's not a single vessel. And this is the classical case that we
Okay,
opened
now
the circumflex
can we
before.
Distally.
Yeah.
How
And,
distally you have
and
to
therefore
go?
now we are doing the RCA. But you're right, you should wait about 3 months. But in this case, I'll want to have some idea.
Little die.
Yeah, because we have the same place, the done.
You have to go distal.
Yeah, a little further.
Yeah. Because if we need another strand, I'm not going to pull the guide liner back a lot. Some die.
Give a little die.
Pull back here, right? I think we
That's
are good
okay.
here.
We're good. Okay.
Now pull the guide liner back. We may need another strand.
Yeah, we may need proximal another stand. Yeah, you want to pull back a little bit?
Good.
Good. The stand.
Some die there.
Good.
Some die. Good. So
Okay.
just about that
I'm going
branch, you know the bifurcation is, we stop there, going up. You want to put a 20 or a 16?
Proximal will take a
20.
3 or
3 or 20.
And it took
14.
extra time, but this is what people wanted to see, the struggle, but ultimately step-by-step techniques to get to this kind of very challenging case. keep it.
Cannot wait to see the
Done
picture and
proximal edge.
how spectacular I think this is going to look.
When is it 20?
For our viewers,
3:20.
next session is April 15, and in the meantime, I hope you continue to watch the peripheral interventions companion website too.
And we are going to add, actually, we are making a decision, having a meeting today to start the structural heart disease session, maybe every 2 months or so, every other month, not every month. And the first will be in April. What we'll do is, as you know, we have 4th Wednesday is the endovascular, 3rd Tuesday is coronary, and we'll make it up the 2nd Monday. We'll try to make
Are we good?
the
Overlap?
structural heart disease session.
Fantastic.
Okay. Some die? I think overlap is good, right?
Yeah.
Too much, okay.
No, that's good.
Okay, let's take a cine here.
Good.
Good, go.
Okay, go. And then go inside and just go high pressure. 12, 14, good. Let's go a few millimeters inside. Good.
Sharpa guide did it.
Hmm?
Sharpa guide.
Huh?
Sharpa guide, we have a
Yeah.
good support. I think we should start using these guides for this complex.
Fine. Now, let's bring back your little bit and we'll take a picture. And then we finish it because enough. Okay, let's take a cine.
Again, same in this tough situation, you're not taking your wire out, nothing. If everything looks good, that's the time you'll take things
and
out.
leaving the guideliner there
Yeah,
too.
has to be.
Spectacular.
Wow.
Absolutely spectacular.
Good. All right, let's complete this long marathon session. If we can go back to, this is fantastic, excellent results. The few points now, the same coronary anomaly and near DES trials. The true coronary anomalies occurs in 1 to 2% of cath cases, and engaging the anomalous coronary ostia may be challenging, particularly right coronary. Potentially high risk anomalies are best treated by surgical approach. Second, randomized clinical trials have shown similar efficacy and safety of currently available
you get your
2nd, 3rd generation DES. In truly complex cases, superiority of one DES over other needs further investigation, as you asked me that what is your preference based on the complexity. And of course, with again, you need to develop the stent which you really love the best, performs best, and of course has a lower event rate of thrombosis and other dissections. Longitudinal stent deformity is unique to platinum chromium DES, but without clinical sequelae. That's the key. It has been consistently shown that without any clinical sequelae. So quickly go to the 3 questions. Following are the benign coronary anomalies except early RCA bifurcation, separate left coronary ostia, left main coursing between great vessels, anterior course of anomalous left main, and retroaortic course of the left circumflex. Second, following are the recent randomized trial of DES except compared to host assure, platinum plus, 22, and resolute all comers. And the last question, longitudinal stent deformity occurs with which DES? Cobalt chromium, everolimus eluting stent, platinum chromium, everolimus EES, platinum chromium ZES, platinum chromium resolute, and cobalt chromium resolute. And with that note,
Question number 4, which stent has probably eliminated the longitudinal compression?
yeah,
Anu, final comments from you. I truly thought this was an exceptional teaching case and how you handled true complex anomalous RCA.
yep.
I just want to, I think go over the case quickly, so I don't know if people actually followed through. The goal was same, which was the guide selection, which we went through A, B, C, D, and for D we knew was the AL, and we used the MAC, but MAC was right sitting there, but would not give us any support. Every time we go with the wire, that next time with the balloon, with the over the wire catheter, everything was coming out. When we did with the Sherpa catheter, though it was AL 0.75, it was, we were able to, the guide was just sitting at the ostium and wire it. Now going through is, what are the couple of strategies that you can use. That is the first thing, that we selected was that have the guide liner in the guide, and we saw that as soon as the guide liner was just with the wire, we know that guide liner will not go into the vessel. We needed the anchor balloon technique, and once we had a balloon in that area, then we were able to get the guide liner in, and once the guide liner was in, we were able to subsequently get the balloon. And that's where we were struggling initially, that with over the wire catheter we went with the Miracle as well as the Confianza. We were able to make some channel, but then nothing would go further because there was no guide support. And to have a better guide, next guide would have been to have the guide liner, but we can't get the guide liner in without balloon anchor, and that is where we were going back and forth. But by using the better wire which was run through in the branch, we were able to get the balloon, which again is 1.2, which was a 1.25. Yeah, 1.25 balloon. We were able to anchor, and then 1.5 balloon, and we were able to get the guide liner in, and that's how we were able to pre-dilate, then get the wire in the main vessel, pre-dilate, and able to stent both this area. And we showed the same thing is once your guide liner is in and you're not sure about the stent length, just go for the longest stent you think you can, because you cannot be giving dye and looking for exactly where to place it or where how far you have to come back. So just go for the longest length. As you see, you can't give dye, and there will be dye staining which can give rise to problem. Just go with the longer stent length and stent the vessel area that you had to. And going back to the question that was initially asked, that why should we do a case like this, is interventional cardiology is going to the not the second generation, maybe third generation, where we have to challenge ourselves and take more challenging cases, and that is where this our live webcast is going to help in understanding and also doing this kind of challenging cases safely, and we give the tips and tricks to do these cases, so all over the world people are able to take care of these tough cases.
And the one question about the delivery of the newer stents, and you saw it here, that how the Promus Premier went despite this tortuosity, and so of course helped by guide liner. But I think the earlier Resolute Integrity, in my opinion, the year before had a superiority in terms of the delivery of a stent in a tricky situation, tortuous distal area. But both Promus Premier and the Zions Expedition, I would say that kind of have come all three at the same level. So they basically have leveled the playing field in terms of the deliverability of the stent now.
Samin, in closing, I want to congratulate both Dr. Kinney and you to having archived the most memorable case. I think back almost 90 minutes ago when you began the academic exercise of teaching how to handle anomalous right coronary artery, the most appropriate manner to select the guiding catheter, which I think is the key to this case, and then using the skills of 30 years ago over the wire to the beautiful use of a buddy wire as well as a guide liner. I truly think viewers will find this as an exceptional academic exercise. Congratulations to you again, to your fellows who stuck. Often these are the cases where I think the role of the second operator was as important in deftly handling the catheters. So my congratulations to all of you. Samin, introduce us to the fellows to your right.
Yep. We have Mayur Lakhani. Say hello, and then we have Rikesh Patel.
Congratulations to all of you. We are going to conclude this session and be back for the next one on April the 15th.